This meeting is now being recorded.
Hi everyone, this is Chris McCracken, and well, Yahoo, we have a webinar and a call, I think. So I hope
we're in a room that I thought was a storage room.
We didn't know this room existed here, so we're doing well. I am a program coordinator with Women's Wellness Connection and Wise Women, and I'm going to let everyone else in the room introduce themselves.
Hi, I'm Nicole Brasser. I am also a WWC and Wise Women coordinator.
Emily Kinsella, I'm the section manager for WWC and Wise Women.
Ivy Hunt, program coordinator.
And Shannon Lawrence, evaluator.
You may not have heard them because they're not sitting near the phone, but that was Ivy and Shannon. Okay, quick reminder that we don't take roll anymore at these calls, so you need to remember that you are here and let us know on the next progress report that you're here. That's pretty much the message. We had a couple other announcements. Do you remember what they were, Emily?
No. I thought you were keeping track. I remember one is a reminder that Dr. Shepard will be doing a webinar, a clinical webinar on HPV genotyping on Tuesday, May 3rd. So we hope you all can join us for that, and I am not certain what time that's at.
I think it's at noon. It's over the lunch hour kind of thing.
And then the other thing we hope you join us at is the Women's Health Conference, which will be WWC, Wise Women, and Family Planning contractors all together May 16th through the 18th in Breckenridge.
Right.
And I think the other ones were already passed. It was do your progress reports, which were already due.
That was passed, yeah.
So, yeah.
Okay, great. Shannon, can you come a little closer and tell us? Give us a little heads up on your project.
So, again, this is Shannon Lawrence. I'm an evaluator for WWC Wise Women Care Coordination and the Outreach Program. We've heard from you in the past that implementing WWC programs can be time-consuming and onerous in certain areas, and we'd like to know a little bit more about that to see what we can do to help improve the situation. And so we're going to be conducting a time and effort study in May, and we would like to strongly encourage you to participate because we really need to understand the differences in how implementing WWC programs affects your staff. This is really about how time spends staff, and you'll get all kinds of information in introduction letter and good fun stuff, but we really want to just better understand that, and in order to make any changes or to reduce that burden, we really need to kind of whittle it down to small pieces, and so I just wanted to give you a heads up that that's coming during the month of May. So thank you.
Great, thank you, Shannon. I think that was it. I think we didn't really have too many more updates. Anything? Okay. Great. So today we listened and we heard that you wanted to talk a little bit about subcontracting, maybe give us some feedback, maybe hear from some people, so that's what you're going to hear today. So what I want to do is start with a basic overview of what's in the toolkit and what is required of you or of your agency. So every agency should be able to provide all the procedures that are on the CPT code list. Either at their agency, at the agency themselves, which many hospitals can, or you subcontract for those procedures. We would like that as much as possible, and we know Colorado's a big state, that clients not travel more than 60 miles for that service. If you know that you have some contracts or subcontracts that are clients do travel more than that, if you would give your program coordinator a call and just let us know about that. We probably already know that that's what you're doing, but just checking. The other thing is in your subcontract, you must include, well, with your subcontracts, as with your work, clients will not be charged for WWC services. And if there's anything above and beyond the the procedures, if the client might be charged, she needs to know ahead of time before the procedures happen. You're responsible for communicating with your subcontractors. We don't here at the state enter into that relationship at all. We hear some best practices and that kind of thing, so we might know about some of those things, but we are certainly not experts in that area at all. And I'm going to ask a couple, two of your peers to speak today, because I consider them experts in their particular situations. So I want you to look at bullet number 3 that says that you are responsible for the timeliness of the cases. So if your subcontractor is not providing information to you within a timely manner, you need to work on that relationship. Some agencies include that in their subcontract, that they need to provide results within a certain time frame so that you as an agency can meet your indicators. I think that's it. Oh, here we go. Sorry. So you know that these are some of the types of procedures that are quite often subcontracted out. The bottom line, the bottom row there, is that PAPs, pelvics, clinical breast exams, and education may not be subcontracted out. That must be provided at your clinics. I think that might be lost out. So the phrase MOU is up here because we don't tell you must have a contract or an MOU, that kind of thing. You just need an agreement, a written agreement with your agencies. We call them subcontractors because in general, that's how we feel, or that's how we think of them. And this slide talks about, or kind of outlines some of the key elements of those of what is on the contract or MOU.
I would say a key point there too is that really your agency, it's your legal document and your legal agreement with the people doing the work, and so it should outline the payment, and what we're looking for is that you have one and it's up to date, that it outlines some of the requirements we have, but otherwise everything else in it is really up to your agency and should go through your own legal team as far as what required words and stuff might be in there. So just to let you know, like that's where it gets tricky of like we don't, your agency decides what your contract, like we decide what our contracts with you all say, you need to decide what it says. We'll look for the key pieces of things related to WWC, but most of it's probably your own legal terms and things like that.
Right, right. So I think what I'd like to do is have our two speakers share their information now, and then you can ask them questions or us questions. afterwards. So let's go alphabetically. Ashley, are you on the call? Ashley Armstrong is from Planned Parenthood, and I asked her to share a little bit. And you'll need to star 6, Ashley, because they have to deal with contracts all over the state. So they have this huge network of contracts.
I'm here, Chris.
Hi, thank you.
Hi.
I'm going to turn it over to you.
Great. So I'm Ashley. I work at Planned Parenthood, and we have 20 different health centers all across Colorado, which can definitely make subcontracting a little difficult just because we do have to have a lot of contracts in place to be able to meet the needs of all of the different health centers that we have across the state. So one thing that we did to try to make the process a little bit easier is we have a template for our MOU that we have already had approved by our legal team. And so if I identify someone who we'd like to create a new subcontract with, I can easily just send them over the template that we have, and then we can go into kind of the back and forth if they have any thing that they want adjusted on the template or on the agreement that we have. And then what I do is I also have an Excel document that has each of the providers that we have contracts with and all of their contact information, just so I can keep track of who we have active contracts with and the contacts there as well. And then each year when we roll into a new grant cycle, I will mail out the updated CPT code list to all of the providers. And I also mail out with that subcontractor information sheet where they can update if there's been any changes within their organization to who I should be contacting or anything like that. And then in terms of billing, what we do, all the bills, it says on our referrals to send the bills directly to our accounting department to be paid. So that's how we kind of communicate with them where to send the bills. And if there's any issues with that, which sometimes do arise where bills will get accidentally sent to the patient or anything like that, I just have the health centers contact me directly, and I follow up with the subcontracted provider to make sure that it gets billed properly and ensure that it doesn't happen again in the future. So that's kind of the overview of how I manage all of the different subcontracts that we have. But it's definitely a challenge, I will tell you that.
I bet. I wanted to ask you about something you said. So it sounds like you've got your MOUs with all of your providers or whatever. Subcontractors, thank you, the network. But annually you send them an updated CPT code list. So
yeah.
That's the one we release like at the beginning of every fiscal year.
Exactly.
So you don't change.
Go
ahead. So you don't change.
Go,
Ashley. Ashley, go.
I also what I do, because I know that the codes do get updated in January, but the grant cycle doesn't roll over until July. Mm-hmm. And so I just give the updated list to my accounting department in January so that if there's any new codes that are being billed by our outside providers, that they're still able to reimburse them for those. But I do make it clear that we won't change the actual amount that we're reimbursing until the next grant cycle begins in July.
Great.
So Ashley, how long, I have 2 questions. No, we're learning a lot from you. So are your subcontracts then, how long are they written for? Because it sounds like you're not updating them annually, you're just updating the CPT code list. So how long are they written for? When would you actually have to renegotiate the terms and things?
We have them written to just auto-renew unless there's any issues that need to be renegotiated. And that also keeps the burden to not have to sign a new contract with them every single year.
Mm-hmm.
And then do you have language in there about providing the new CPT codes and using the new CPT codes?
Exactly.
The other question I had was about the billing and about, I think everybody runs into this where a patient accidentally gets a bill and they get all perturbed because they thought they weren't going to get a bill. Do you have your clinics do some proactive language or something that they say to their clients to kind of give them a heads up? If you get a bill, call me or something like that?
I do believe that they have that language on there, and then it also just on our referrals is very clear, like this is a grant-covered referral, just so that the provider knows as well that the patient shouldn't be responsible for it. It says like at the very top, WWC grant-covered, imaging referral, or whatever the referral might be for.
Yeah, great. Good. What was I going to ask about? Oh, I was going to ask, do you get pushback from your subcontractors on not changing the rates, the CPT rates, immediately? Or is that because it's in the contract, it's not a problem?
I think that happened a little bit in the past, but a lot of these subcontracts we've had in place for a long time. We've already kind of built that relationship and made the program very clear as to how we run everything. So that hasn't been an issue recently at all.
Good. Okay. I'm going to save questions for the end. Okay, so stay tuned. Stay on the line, Ashley.
Okay.
Did you have anything else to add? I'm sorry, I should have. Actually, no.
That's about it.
Yeah. Okay. Okay, Charisse Callahan is from St. Joseph Hospital, and many of you, and they're in a unique situation because they're a WWC agency and a subcontractor. So they have a unique relationship with everyone, and they refer within their own hospital system. And so I said, Charisse, you've got a complicated situation. Tell us how you deal with it. So are you there, Charisse? *6.
Can you hear me now?
Now we have you.
Good thing you said *6. I'm looking at it going, I unmuted it. So yeah, we're in a pretty unique situation in our little world. So as Chris said, we're both a subcontractor and a contractor. We have all of the different programs here. We try to get everything we can. Basically, the GME clinics, the Bruner, Caritas, and Seton, do not do any contracting, but our breast care center and our mobile mammography unit do quite a few MOUs. So they do the screening and diagnostics as needed, and go around, and they have MOUs with a variety of places, and they basically do the Denver metro area, but we have been known to go up the mountains and out to the plains as well. The clinics don't, because we're all one entity, so we have full circle continuum of care. So if they're primary care in the Caritas clinic and they go over to the cancer center and come back and just keep going in circles, so we don't need an MOU. What else do you want to know?
Do you have tips as a subcontractor? So I think a lot of the other agencies subcontract with you for the mammogram ban, right? Is that correct?
Correct. Yes. Yes.
So from your side, is there a thing that since you have to kind of manage all those, is there a way that makes it easier or less, things that make it easier as a subcontractor to keep on top of it?
As a subcontractor that's trying to contract with us, something for everybody to know when they do subcontract with St. Joe's Mobile Unit or Breast Care Center is that our legal system only allows us to use our own MOU. So if a location is requesting to receive our services, it's better to let us know they would like to contract with us and receive our services than to start writing a contract, because our legal department will not accept it. We're also requesting that all locations have WWC funding.
So you're not subcontracting with non-WWC clinics at this time?
Not unless that clinic is planning on paying us a rate for patients.
Okay.
So if the patients are insured, by all means, we will subcontract for any insured or WWC eligible. We're no longer subcontracting for Komen screening dollars.
Okay.
Or, well, we are. If the other locations have Komen screening dollars, we will go until their screening dollars are out, and then that's it.
Got it.
We're no longer offering basically a self-pay price on our mobile mammography unit.
Okay, good to know.
Is there something, Sharice, from your side about the invoicing of, like, how do you all as subcontractors or an agency, you know, thinking when they're talking to a potential subcontractor, how do you sort out that, oh, this time we bill the agency, that time we bill the client?
It's a lot of fun, let me tell you.
Okay, that's what I thought.
Yeah, we try to create client bills for all of those places that we are subcontracted with. So let's use, I don't know, Inner City as an example. I don't even know if they have WWC funds, but they're on my brain.
They do.
Okay. We contract with them as we see their patients with Inner City WWC funding, we will send them what we call a client bill, which is a once-a-month invoice with the patient name and what services they received, so that Inner City can then pay us just once a month versus these random invoices in the mail, and then we don't have to bill the patient either. So the patient doesn't get the bill as well. And that's what we've found to be the easiest, is to treat all of our WWC. We load WWC like it looks like an insurance in our system, so that we can try and catch these without billing the patients, because it's scary enough to get a mammogram, much less than get a bill for it when you were told it was going to be free, you know?
Yeah. Okay. Thank you. Is there anything else? Yeah. Does anyone have any questions for Sharice or Ashley or us, I guess? We'll start with subcontracting, and then we can open it up for whatever.
Well, and this is a forum of...
I have a question, actually. Can I chime in?
Yes? Who is this?
This is Danielle from Salud.
Hi. Go ahead.
Hi. So how long, Ashley, how long did it take you to get everybody that you guys needed contracted specifically for WWC? Did you do it all at once, or did it just happen over time?
To be honest with you, I actually don't know the answer to that. I've been in this position about a year, and I kind of came into everything already being totally set up, because we've been a WWC provider for a very long time. So I'm not quite sure what the history is in terms of our subcontracting.
Okay.
Sorry about that.
That's okay. That was my question.
Does anyone else on the line have some, whether you did them all at once, any other agencies, did you do them all at once, or do you do them as you sort of
as needed, or?
*6 to unmute.
This is
Danielle. Go ahead, Ashley.
I was just going to say that, you know, in terms of doing them all at once, I think it is a little bit easier to do them one at a time and just make sure that all the processes are in place. Because it does take a little bit to actually build that relationship and make sure that everything is getting billed properly and that the referral system is actually working and that patients are, you know, not running into any kind of issues. So that might be an overwhelming process to do if you know, if you're trying to do 10 new contracts at once. But of course that depends on, you know, how many contracts you have in place and whether or not you're actually meeting your patient's needs at the moment.
Okay, thank you.
What I was going to say before that is consider this maybe a forum of, you know, we often hear that subcontracting is one of the hardest parts of WWC, and so maybe this is a little forum of your peers of issues you've run into and maybe get ideas from how other people have resolved it or what they've done, or things you want to, other agencies want to share of what's really going well, they're like, aha, I found this amazing way to do it. You all should do it too.
This is Blair from Boulder Valley Women's Health. I had a question for Ashley. You said that you sent along the updated CPT codes and everything once you got them to all your subcontractors, and then you mentioned sending like a letter or something like that with them, and was that basically just to say, hey, here are the new prices, let us know if you have questions or if anything's changed?
Yeah, that's exactly what I do. I send a letter with it, so I'll send most of them, we already have the auto-renew with them, so I don't have to send a new MOU, but I just send a letter just introducing everything again and saying, here is my contact information, here's the new rates that we'll start paying you July 1st, and contact me with any issues.
Okay, perfect. Thanks.
I wanted to say that one thing that we do at WWC, this is Chris McCracken, if in January there are any brand new codes, like in the past couple of years that's happened, we will release that and kind of have a dual level CPT code list with the new codes because your subcontractors are going to start using those right away. So, you know, if you know that has happened, you know, look on our website to see if it's there, and if it's not, you can contact us. It may be in the works, or maybe we didn't know about it. Don't forget to *6 if you're talking to yourself. What's the most challenging thing about subcontracts? I know I hear it on site visits, so let's hear something.
This is Rebecca from San Luis Valley Health. I think the most challenging thing that we have with subcontractors is the contract has been in place for so long that when they have staff turnover, it isn't necessarily part of the new process training. So when we have to refer out, it can be a real challenge to get things back online because people don't necessarily know what they're doing anymore.
Are you talking about on your side or on the subcontractor side?
On the subcontractor.
Yeah, okay. Especially what I've heard stories, especially if it's their billing person. That could be a challenge.
How have people overcome that challenge?
They haven't. They have not. Okay.
This is Ashley from Planned Parenthood. I think the way that we try to overcome that is by making it very clear on our referrals where the bill needs to be sent. But of course, you know, that referral doesn't always get to the billing department, or a patient may lose the referral. So in those instances, it's not, you know, the most perfect system.
So your referrals, it's a sheet of paper that you give to the client to take with them, or do you fax it over to wherever? How do you work with it?
We give it to the client to take with them, and we tell them that they have to have that referral with them when they go to the provider.
Yeah. Yeah, that doesn't always happen. Okay. You guys, questions?
How do you guys handle, I'm trying to think of the questions we get. I mean, the questions we get the most is we get clients who are called because they got a bill from someone and they didn't want to get a bill. And we usually hand it back to you guys. But I'm wondering how you guys, do you have any systems like the referral sheet that Ashley talked about, or any other strategies that you have to kind of ensure the client doesn't get the bill, or either that you tell the client, or something you give the client, or something you have arranged with your subcontractor providers that has helped clarify that? Because I think that is an area of kind of often confusion for on both sides, for the subcontractor and the client.
Hello? Someone's there?
Hey, Chris, it's LaDonna from Trinidad. So one of the things we do right off the bat is tell the patients, because it's happened several times down here, if you get a bill, just bring it back to us. That way, before they leave, they know that this is, I think a lot of people are a little skeptical because they said, oh, this is a free program and then I still got a bill. So we just tell them, if you get a bill, just bring it to us. You are not responsible for that bill. So we just tell them right off the bat that they are not responsible if they get a bill.
Good. Good. And do they follow through with that? Or do they?
Yeah, we've had several patients bring in their bill saying, you know, here's this bill, and so we just take it and make sure, you know, that it's been taken care of. This one patient was, it was a subcontractor who was kind of getting harassed, and so we had to fix that, but we actually switched subcontractors, which actually leads me to a question, because on the website, you had posted if there was a subcontractor greater than 60 miles, it has to be approved by you all. So our subcontractor for all our diagnostic mammograms is in Pueblo, which is 80 miles from us. So we don't have to redo any of these contracts as long as they've already been approved, correct?
Correct. And I think at this point, I know that about you, your agency, especially because of your location. If you're pretty sure, or if you're not sure that your program coordinator knows about any of your long-distance subcontracts, let us know.
And it's more so just so that if we can help you find someone closer,
right,
help do that.
Right.
Yeah, we're going to Springs, and then we're having some issues with Memorial, so we actually are now in Pueblo with St. Mary Corwin and haven't had any issues with them. So location-wise, that's pretty much all that's available to us.
Yeah. Yeah, absolutely.
Is it pretty easy for you guys to find subcontractors? Or I feel like some communities have had, like the one provider in town doesn't want to play. And if maybe does that happen to you? And do any other agencies have sort of strategies for finding subcontractors? And how do you entice them, maybe, or how do you talk to them about the program and get them on board?
Hey, Emily, this is Debbie at Spanish Peaks.
Hi, Debbie.
I just wanted to make sure that Mount San Rafael knows that we have a mammography machine at Spanish Peaks, too. So don't necessarily have to go to Pueblo if they don't want to.
Well, we actually have a new mammography machine we had put in last November. So we do have mammograms. It's for our diagnostic testing.
Oh,
so for like biopsies and stuff like that, we're sending to Pueblo.
Okay, we do the same thing. We use Pueblo radiology for our diagnostics.
Yeah.
Okay, but thank you. I appreciate that.
Yeah.
Nearly a connection made there.
Nearly.
Wow.
And that's something we can help too if you're struggling. We can, if Trinidad was Mount San Rafael was having a hard time, maybe put you in contact with Spanish Peaks. Who are they using? What are their subcontractors so that you can gain from each other?
Right. We do have a list. I mean, of course, you guys know, anyone who does eCaST knows that it's in eCaST, and so we know who's being used, and you've told us about, and it's in eCaST. So we can, in the sense, we can't refer and say, hey, this is a great subcontractor. We can just say this is a subcontractor in this town or whatever. But we could connect you with each other. Any other questions or comments or does anyone love subcontracting? We want to hear from you. Okay. Yep, no one loves.
And I'll just share the importance of it, and probably some of you have have experienced this, that really it's there for when things go wrong. Unfortunately, you know, verbal agreements and those kinds of things work really nicely until something goes wrong, and until they're trying to charge you a crazy amount, or they're trying to charge your client something, and then you have to pull out your subcontract and say, nope, look, here, you signed and said you'd do this. And so it really is to protect you, it's to protect your patients, it's to protect your providers too, you know, your subcontractors of, you know, we only cover a limited amount of things, and there's, and that, so it needs to be clear on that, and it really is protection. Hopefully you never really have to use it, it's just a nice, you know, nice thing to have, but it really does come in handy when there becomes conflicts, or your client got charged for a biopsy, or, you know, and you need to take it back to the provider, or they're like, nope, this is what we charge, and you say, nope, look, you agreed to this Medicare rate. Those kinds of things. So it really is handy that way.
It is. Any more questions, comments? Well, okay. Oh, yeah, if you're typing in questions, we didn't have any. We couldn't see them. Nope. Okay, thanks. Just another reminder, we're not taking rolls, so you need to remember. And this is recorded, so you can send someone back to it. You can go back and listen to it again because it was so riveting. We appreciate you that you're here. Any last announcements in this room?
I have one more.
Okay.
I went and found the email.
Okay.
We are offering, WWC is offering a scholarships to go to colposcopy training in somewhere? Rhode Island.
Rhode Island.
Says Ivy. So the applications for that are due like May 17th or something. Go look at your previous updates, or email Angie or your program coordinator if you did not see that. But it's to send providers who will actually do colposcopies. Either they need to be trained to do them, they don't know how, or they used to do them and it's been a few years and maybe they need to a little refresh before they start trying that out again. But there is the AFCCP colposcopy training in July in apparently Rhode Island. And we can pay for the registration and travel.
Yeah. So we encourage you, if you're not a provider, let your providers know about this opportunity. Well, thank you very much, everyone. Have a good day. Hopefully you have some lovely weather where you are, and we'll talk to you soon. Bye.
Thank you, ladies.